So looking at this slide on the top, you just see an open lumen with plaque erosions compared to the bottom, which is plaque explosions. And that's why women present with more acute coronary syndromes, such as unstable angina and non-QA of MIs. So it's difficult to diagnose and delays in treatment, as you saw in that last patient. So this was the WISE study. About 50% of women are sent home with normal coronary arteries compared to men. And most of the common reasons is they have what's called macrovascular endothelial dysfunction. So if we can find a way to look at women's blood vessels and look at the endothelium early on, we can get a good idea of what's going on with their presentation, their symptoms. So this is if you take a look at this, on the left is the lumen of a coronary artery, 3.5 millimeters. On the right is a lumen of a coronary artery, also 3.5 millimeters. But if you look at the difference on the right, you see an outward progression of plaque. And if you looked at, on the left is early disease, on the right is advanced disease. So if we're doing an angiogram and we're seeing this, it's going to come out to be a normal angiogram. And this is why women get sent home, because their plaques grow outward, not inward. So they're having plaque erosions, not explosions. So this is a very important slide, and that's why cardiac catheterization in women is actually now not really the gold standard. There's other techniques that we can look at the tissue, such as CT angiography and some newer techniques, because here you can actually miss a blockage. Do I get extra minutes because my slide presentation is not working? No. So on the top is a typical picture of an angiogram, what it would look like in a man. And you can see at the top, right here, is a focal single lesion. And at the bottom, it's bumps throughout. It's small throughout. This is abnormal vasomotor tone. The blood vessel is actually going to be diffusely diseased compared to more focal disease in a man. This is a magazine called The Atlantic Monthly, and the reason why I put this in here, I put a couple of history slides in here. If you look at this is from 1989, and I think it's hard to read, but lowering your cholesterol is near to impossible with diet, and is dangerous with drugs, and it won't even make you live any longer. This was 1989. So atherosclerosis is a manifestation of poor lifestyle and dietary choices. The American College of Cardiology recently changed all their guidelines with women, looking at whether we're going to treat patients with drugs immediately or do lifestyles. So now the number one thing that we do for 3 to 6 months before we put patients on statins, if they're intermediate and low risk, is basically start lifestyle modifications. So I just want to give a few slides on atherosclerosis. I know it's not really a science lecture, but there's about 128 degrees predicted rise in mortality with coronary disease by 2050. And one of the reasons why this is so bad right now, it has to do with obesity trends and diet. This is a slide on the left is something called the intravascular ultrasound. It's actually it's a sonogram inside a coronary artery. And if you look here, this is the lumen right in the center. This is cholesterol plaque. So it's atheroma. This is a 32-year-old female who was involved in an accident, and her heart was looked at before it would be used for a heart transplant. So if you look on the right side, at women's ages between 20 to 29, there's a 37% prevalence already of atherosclerosis. At age 39 to 40, a 60% prevalence of atherosclerosis. And from all these slides that we saw before about premenopausal women, they're okay, they have estrogen. Compared to postmenopausal women, that's when we need to start worrying. It's not true. If you look at this, it's hard to believe that 60% of women in their 30s already have prevalence of atherosclerosis. So it's not just about menopause. Estrogen is not the major protector. So another case, 55-year-old woman comes to the emergency room with shortness of breath. EKG revealed an acute MI. We see ST elevations in certain leads of the EKG, V1 to V4. Cardiac enzymes, troponin were positive. She had a catheterization performed. So this looks a little different. If you look at the top, you can see left anterior descending artery, but in between the arrows, it looks a little thin compared to where the arrow tips are, that's thicker. So the culprit lesion is in the proximal LAD, not the ostial. It's just in there. It's a thinning. So she underwent what's called a PCI, percutaneous coronary intervention. It's a coronary stent. And you can see the arrow. That's what a stent looks like. She did well. She was sent home. She came back 133 days later with nausea and dizziness. While waiting in the ER, she had a witnessed cardiac arrest. EKG showed ventricular fibrillation. She was shocked with a single 200-joule shock. And this is what we call sudden cardiac death. She was revived. We looked at her stent to make sure it wasn't closed, because that's usually what happens. And if they present soon, and if you look at her stent, it's still open. So she had what we call a patent stent in the proximal LAD. So what happened here? We look at, this is from a big registry of 4,000 patients. And we're focusing here on what's called non-culprit lesions. What this means is at the time of her angiogram, where the LAD showed that blockage initially, the right coronary artery on the left was normal, but 133 days later, on the right panel here, you can see she had a blockage. So how did her heart in the right coronary artery change from no blockage to blockage in 133 days? This study done by the National Heart and Lung Blood Institute looked at plaque progression. So she actually went from 42% to 84% in 5 months. She basically doubled her plaque burden in her right coronary artery because, remember, it looked normal before because her plaque was growing out, not in, so we couldn't tell. So she probably had plaque here on the left. So was this the right test to do for her, or did she need other testing done to see where this plaque was? So what this is called is, it's like a volcano waiting to eruption. We call these vulnerable plaques. When is it going to occur? A vulnerable plaque is a lesion that puts a patient at risk for a major cardiac event. And she had a major cardiac event. She had a sudden cardiac death. So if we look at this slide, you can see this, what we call a thin cap right here. It's probably hard to see from here. I have another slide that can show you better. But if you look at where it says A is a thin covering, and B is actually a large lipid core. So these caps are supposed to protect the plaque. If the caps are thin, they can't protect it. So this is another way to look at it. It's called a thin cap fibroatheroma. So all plaques have these caps. If they're thin with a large area of lipid underneath, they can rupture. And when they rupture, they form this, which is a plaque rupture, and you can see the blood inside the lumen. So the impact to detect these vulnerable plaques would be a major breakthrough. And this was actually done and performed. It's a different lecture. I'm not going to talk about vulnerable plaques and ways to do it, but there's ways that we can look at temperature of plaques, size of plaques, hardness of plaques, spectroscopy of plaques,